One's always assumed that clearly I must know something about OB. He gets the same because all of his OB friends ask him all the skin questions, and he's like, wait a minute, ask her, not me. So it's a privilege to be here. I'd like to talk to you a little bit today and kind of give you a perspective of what a dermatologist sees in the skin during pregnancy. You guys are really the experts on that because you're the ones seeing it all the time. But what I hope to do also is to let you in on a few little secrets that you may or may not know about your dermatologist. Now, by this, I'm going to probably rat out a lot of my specialty, but we all laugh among ourselves for this. For example, the things you'll hear from me today are, and you've maybe seen this, dermatologists are terrified of pregnant women, okay? We have no clue, and we don't want to give them any prescription medications. And the caveat of that is we also don't like prescribing oral contraceptives. How many of you have gotten a frantic call from your dermatologist to put one of their patients on oral contraceptives? We'll give the most toxic immunosuppressive drugs, won't even miss a beat. We'll give isotretinoin without a problem, but we're terrified to start them on the oral contraceptives that she needs to not get pregnant while she's taking that. So please forgive us for those. It's just part of our training, and I try hard. I'm an old-fashioned dermatologist who still carries a stethoscope, so I try hard to fix these, to remedy these issues. But so I have no relevant conflicts of interest. We're all hoping somebody will pay us to talk about these types of things, but it would seem unless you're speaking about fillers or something, nobody really wants to pay you to talk, in dermatology at least. And some of the medications, if not most of them I'll talk about, are used off-label because for most of our dermatologic diseases, there are no on-label drugs. So almost all women experience some sort of change in their skin during pregnancy. What I try to help dermatologists ask first and foremost is, are they normal changes or are they abnormal changes? And once we figure that out, what can we do about them? In some cases, nothing. And in many cases, fortunately, we don't have to. Because there's a lot of changes in the skin that occur during pregnancy that are considered physiologic. I mean, of course, we all know about the stria, and I will talk about those a little bit today. Vascular changes, largely a function of hormonal changes, but also the cardiovascular changes that occur. Varicosities happen in about 40% of women, but spiderangiomas are common for the high estrogen states. Most of those will improve somewhat postpartum. If you have a woman with a lot of spiderangiomas and they don't resolve within a few months after pregnancy, we start thinking about liver disease. Mucosal changes. Gingiva can become hyperplastic. We can get the epulis or the pyogenic granuloma both in the mucosa or on the skin. Those may resolve, but they're often painful or they bleed, so often they need some sort of surgical intervention. Hair changes. Who gets the postpartum hair change? You guys are lucky because if you see your patients at 2 to 6 weeks postpartum, you may not get them complaining of the significant hair loss. I get them later for that. There are also nail changes during pregnancy. Nails can get rough. They can develop lines in them. Sometimes if they get a lot of lines, it's not a problem. If you get one pigmented line, that could potentially be a problem, and I'll talk a little bit more about that. And of course, hyperpigmentation is one of the physiologic changes in skin during pregnancy, as are, unfortunately, skin tags. So hyperpigmentation is probably the most common skin change we see during pregnancy, and the vast majority of us who are or have been pregnant experience this during pregnancy. Darkening of the areola or development of what they call the secondary areola, quite common, most women get that. The skin in the genitalia, which tends to have more pigment at baseline, can darken. The linea alba becomes the linea nigra. We can get generalized hypermelanosis. The whole skin can generally darken. Now, if it's really profound and their skin looks bronzed, we need to be thinking about diseases like Addison's disease. Darkening the axilla, scars can darken, freckles can darken, and rarely we see this darkening of lines of demarcation. Some people are actually pigment mosaics. They have just innately and genetically slightly different changes or different colors in their pigment, and that can become accentuated. Again, most of this pigmentation change will resolve or improve, although it may not ever quite go back to baseline. postpartum. The one we tend to see most is melasma because that's the pigmentation changes that women seem to hate the most. It affects women in about 50 to 75% of pregnancies, and it's more common if your baseline skin is dark for it to get darker. Obviously, exposure to ultraviolet radiation, which dermatologists hate sunlight, but it's because it can hyperpigment the skin, and certainly it's a risk factor for developing melasma. There seems to be some genetic predisposition in who gets melasma or not. And this also, like the other types of hyperpigmentation, may fade, but it may persist in up to 30% of patients who get it. So this is one we are often asked to treat. And the good news is there are generally some things that we can do to help melasma get better. Our old and gold standard, which still works well in many cases, is the old-fashioned bleaching creams, the hydroquinone. The prescription strength hydroquinone is the 4%. The over-the-counter things like esoterica and porcelana are 2%. They're all generally effective if they're used, but they have to be used fairly regularly. And I will harp on this. Anything you do to bleach the skin has to be done in association with sun protection. You can get a great response, but if you get back out in the sun, everything you accomplished will go right back down the drain because the pigmentation will come right back. It turns out that hydroquinone probably works best in a combination form, and there is a commercially available form, which I have no commercial interest in, called Triluma, which has hydroquinone, tretinoin, which is also known to many of you as Retin A, which we use for acne. Turns out to be good for wrinkles too. And fluocinolone, which is a fairly low to mid-potency topical corticosteroid. And when that combination is used, it actually has a better effect on the bleaching of melasma. Unfortunately, it also has a better effect on your pocketbook because hydroquinone can be obtained generically for anywhere from $30 to $70 for a 1 ounce or 30 gram tube. You start looking at the price of Triluma and it goes up to $150 on up. So hikes the price up significantly. And if you've never prescribed these drugs, generally melasma is considered a cosmetic treatment, so insurance probably won't pay for any of them anyway. So when people have to pay this, they're paying for it out of pocket. So I warn them, they can have the best, but it'll cost them. There are other options. Azelaic acid, which is a prescription strength product used for treating acne and rosacea. There are 2 strengths, 15 and 20%. One you may know as Phenacia, the other as Azalex. Those are both used off-label for treating melasma. They work, but they're irritating. They are acids, they're fruit acids. We lived in Vermont for a while, and our patients who liked the idea of something natural liked the idea of using a fruit acid. So, chemical peels, we have used those. I think we're probably gravitating away from that because they worked in some patients somewhat well, but they also can be irritating, and I've seen definitely people who've ended up with irregular pigmentation, so I don't generally recommend those. We have used and still use laser and different forms of light treatments like intense pulse light. I have to say, I think we aren't perfect in using those technologies. I've seen some great results again, but there is some degree of skill of the operator. I think if you're going to consider referring your patient for treatment, be sure you're sending them to someone who's done a lot of them and knows what they're doing. At the risk of editorializing, I think laser treatments are something a lot of people go to weekend courses to do. And just make sure they know what they're doing. It can be problematic in people with darker skin too. Some of the laser treatments that we're using for cosmetic reasons can end up with marked pigment variegation in dark skin. So on the horizon treatments, there are new things coming out. Microneedling is being looked at as a physical way of treating this. There's also tranexamic acid, which is a plasmin inhibitor, interestingly enough. And maybe you could explain to us during your hypercoagulability talk why a plasmin inhibitor might help for this. I think we got to watch for this because I don't know where we're going with that one. I need to point this out because I think this is underappreciated. If you use hydroquinone, and by the way, the safety of hydroquinone during pregnancy itself is unknown, and frankly, most of us, if we're going to treat melasma, usually encourage patients to wait until the postpartum period because some of it may go away anyway. But if you're going to prescribe hydroquinone, you need to be careful about prolonged use because prolonged use can cause an accumulation of homogentistic acid in the skin and result in a condition we call exogenous ochronosis. And what this creates is a potentially permanent pigment deposition in the skin that is far more troubling than the melasma was in the first place. And I have seen this over the years. So what we do is we really encourage people to use it for 2 to 3 months and stop. If they haven't gotten a benefit in 2 to 3 months, they're not likely to get any more. So don't give them an unlimited supply of hydroquinone. And as I mentioned before, whatever the treatment, if you're treating hyperpigmentation, if you're treating melasma, it has to be accompanied by sunscreen. Of course, we like that anyway. Stria, okay? The vast majority of us light-skinned women who are pregnant got some degree of stretch marks, unless you were pre-stretched. Yeah, well, one advantage of being a fat teenager is I didn't get stretch marks when I was pregnant, but that's probably too much information. There's always a bright side of everything. There's many contributing factors to developing stria, one of which is probably genetic. The degree of abdominal distension, how quickly you got your weight gain, pregnancy at a younger age, family history, questionable use of hormones. Here's the bad news. There is absolutely no evidence that cocoa butter does a darn thing. Now, this doesn't prevent the vast majority of pregnant women that I know of from buying it and using it anyway. And in full disclosure, even though I knew it didn't work, I still bought a tub of the stuff. But the internet is just rife full of products that you can buy, and maybe I'll invent one. I don't know that it would work any better than anything else does. But the internet's fun to read about things to prevent stretch marks. We've looked at a lot of other things. Hyaluronic acid originally showed it might work a little bit, but honestly, the Cochrane reviews have shown there's probably nothing topical that helps much. So I don't know how to prevent them. Once we get them, we can try treating them, and we can possibly make them look better. But really what you've done is you have physically damaged and essentially torn the skin. The elastin is missing in your stretch mark. So really there's parts of the skin that are gone, and you really honestly can't totally fix that. We have used, again, topical retinoids, the tretinoin, and that will improve the appearance somewhat, but it doesn't make them go away completely, and again, it can be irritating. I don't recommend use of tretinoin during pregnancy or questionably during lactation. And again, we may have some benefit from lasers. Some of the fractionated CO2 laser actually can destroy little pillars of collagen in hopes of rebuilding it. There may be some benefit from that. Turns out that most of the studies that are showing a lot of improvement are actually treating early stria while they're still inflamed and red. And we really probably need to be doing better studies. But maybe the laser treatments and or the light treatments do help some, but nothing makes the skin go back to completely to normal. Hair grows well during pregnancy. We think that estrogens change the normal cycle of hair growth. Your hair grows in several different cycles. You have an active growing phase, then you have sort of a resting phase, then you have the ready to fall out stage. So when you're pregnant, you get a much higher percentage of your hair in that actively growing phase. And that's why a lot of women feel like their hair becomes very thick and luxurious during pregnancy. Unfortunately, it all falls out afterwards. This is something we call telogen effluvium. And really what's happening is your cycle is shifting from a small amount of ready to fall out hair to a much greater percentage of ready to fall out hair. You can get up to 50 or more percentage of your hair in that telogen stage. And that's when you find hair everywhere. I remember my patients have said, I've got hair in my food. It's everywhere. I can't do anything about it. The great news is this is a self-limited process. It usually starts anywhere from 2 to 3 months after delivery and can go on for upwards of a year. We do occasionally see women who get repeated cycles. They continue to shed intermittently, and I reassure them that I've never seen anyone go bald from this. Over time, it'll usually normalize. The bad news is if a woman was predisposed to getting genetic alopecia, this can unmask this. So they may not quite go back to as thick of a head of hair as they had before. So that's sort of the good news, bad news. They're not going bald, but they may not be quite as thick. So if it really does persist for a long period of time, it's important to check for thyroid disease and for iron deficiency, because both of those things can cause a diffuse, non-scarring hair shedding. So continued shedding, think about that. Also good news, no treatment is really needed, but also no treatment really works. I know some people have recommended topical minoxidil. I don't recommend that during lactation. Biotin supplements, everybody does them. I don't think it does much. And it does usually resolve over a matter of months. Pigmented lesions are a big thing. I am old enough to have grown up in the day and age. There's a few of you who are also old enough to have probably been told, don't worry about moles that change during pregnancy. They get darker, they can grow. Well, it turns out we were wrong. All the studies now have really conclusively shown that moles can darken slightly, and they may grow if they're in an area of the body that's growing. Like if you have a mole on your abdomen, it can get stretched a little bit. But in general, moles should not change significantly during pregnancy. And we should approach a mole during pregnancy like we do any other mole. So for us, that means any mole that is rapidly changing, any mole that looks funny. We like to talk about ugly ducklings. Or any other rapid or concerning change needs to be evaluated and managed appropriately. This has required some re-education among dermatologists, because this is my next confession about derms. We're terrified as a group to do surgery or procedures on pregnant women. I still have arguments with my residents about whether or not they can inject a little bit of lidocaine with epinephrine into a pregnant woman. Well, don't you want to use lido without epi? I'm like, no, pregnant women bleed too. Let's use the epi. But anyway, please reassure your dermatologist that it's okay for them to biopsy that mole and that they can use a little bit of epi and the lidocaine, okay? So what do we look for? We look for the A, B, C, D, E's. Again, we want that ugly duckling. If all the moles are getting a little bit darker, it's much more reassuring than if one is. Asymmetry, border irregularity, color play, diameter greater than 6 millimeters, that's probably the least helpful index for an abnormal mole. I've taken off plenty of 3 millimeter melanomas, and trust me, I'd rather take them off at 3 millimeters than wait till they're 6. Evolution, huge. If a mole is changing, it needs to be looked at and possibly removed. Why? Because melanoma is a huge issue for us in dermatology. And actually, I'd like for it to be more of an issue among your colleagues. In fact, I think our specialty group and your specialty group really need to be talking about this. And this is why. The incidence of melanoma in the US has risen dramatically. It actually has across the world. We're actually second to Australia, where incidence of melanoma is now 1 in 25. But in the US, among those of us with light skin, less than or more than 1 in 50 of us now are going to get a melanoma. That's quite a few melanomas in this room. And this incidence has been particularly striking among young people. In fact, melanoma has the distinction of, unfortunately, now being one of the most common cancers among young people. That's not a number one we wanted to hit. We've made the charts. This was actually in 2014. So in adolescence, we were in the big top 10 of cancer incidence. Now, the good news is adolescents between 15 and 19 don't get a lot of cancers, so we're not talking about a huge number, but I don't like seeing us up there. Why? Because melanoma can be life-threatening. It's the one skin cancer that you may actually die from. We do see melanomas in pregnancy, I think. I don't remember what the number was in the US that we see. It's less than a few hundred, but still, I don't like seeing any. In fact, one of the most striking patients I ever cared for was a young woman who walked in with her 2-year-old and her 4-year-old on each hand to get us to look at the mole that changed during her first pregnancy, but because of her kids, she never got around to getting it checked. And it was clearly a melanoma at this point that was going to kill her. And it broke my heart. So I don't ever want to see that again. Melanoma also has the great distinction of being one of the few cancers that can metastasize to the fetus and the placenta. So although it is somewhat controversial, most authors at this point don't believe that pregnancy or the hormonal changes of pregnancy itself has an adverse impact on the prognosis of the melanoma. We've gone full circle on this. But having said that, if you have a woman who has had a high-risk melanoma and she's at high risk of it recurring, we may recommend that they consider delaying the pregnancy if they're thinking of pregnancy, only to be sure that it's not going to recur. Not that we think the pregnancy itself would impact the outcome, just so they don't show up with a metastatic melanoma during their pregnancy. And the good news is we no longer make any specific recommendations regarding future pregnancies or contraception in a woman who has had melanoma. We used to tell women who had had melanoma not to use oral contraceptives. Turns out that was probably totally wrong. This is my big public health plea, is we need to keep young women out of indoor tanning beds. We need to keep young people totally. And this is why, this is really a lot of what we blame that incidence of melanoma in young women on. We know with certainty, without doubt, that indoor tanning is carcinogenic. And we believe that that's a bad thing. So as a consequence, we've had a lot of legislative successes in the US in the last few years, and now 39 states do either limit or prohibit minors from using tanning beds. Tennessee, Georgia, Alabama, we have restrictions. We generally require parental consent for teens. So at least we have some. We're trying to get better on that. And the reason parental consent doesn't work is studies have shown that young women who tan usually went to the tanning bed the first time with their mother. Their mother was the one who took them there. So parental consent doesn't really work. They've got their mother's blessing, not only their consent. Itching. Many pregnant women itch. So what you want to look for, is there a rash or is there not a rash? If you have a history of allergies, asthma, or hay fever, you may be atopic. And some of us who are atopic just itch, in which case you might be able to treat with antihistamines, topical steroids, and moisturizers. But if there's no history of atopy, you have to look for underlying causes. In this group of women, medications, iron deficiency, thyroid disease, kidney disease, or liver disease, particularly the evil intrahepatic cholestasis of pregnancy, should all be on your mind for your differential diagnosis of itching without a rash. Now, if you have a rash, then that puts us into a different differential. And again, those atopic individuals, if you had eczema as a kid, you may have eczema as a pregnant woman. There's an assortment of kind of itchy, scratchy diseases during pregnancy that we're now sort of grouping together under what we call the atopic eruption of pregnancy. And we usually can diagnose these clinically, and we treat them just like we do atopic dermatitis or eczema otherwise. Gentle skin care, emollients, and Vaseline works great. It's greasy, but it doesn't have preservatives or fragrances, and it's cheap. And topical corticosteroids. So we tend to like triamcinolone, the 0.1% cream or ointment. And the reason we like that is it comes in a 1-pound jar. That is very important, and I'm going to tell you why. Just to comment on the safety of topical corticosteroids in pregnancy. Generally look like they're overall safe. There have been a few studies that have shown possibly an association of use of very high potency steroids during third trimester with low birth weight. But overall, I think they're safe, and I feel very comfortable using mild to mid potency topical corticosteroids during pregnancy. So why do I go back to the 1-pound jar? Because inevitably, non-dermatologists prescribing corticosteroids tend to underprescribe quantity. Why? Because it takes 30 grams, one 1-ounce tube, to cover an average adult once. And if you're putting this all over your body, giving me a 15-gram tube, telling me to put it on twice a day for 2 weeks and sending me out the door, that's enough for my thigh. So we need more. So that's why the 1-pound jar is very cost effective and it's good. PUP. All right, so dermatologists call this PUP. Do you guys call it PUP or PUPS? PUPS, yes, that's the one huge discrepancy between our professions. Now it turns out we're going to change the name anyway. There's a strong push to put it to the polymorphic eruption of pregnancy because it's shorter, I think. So it's probably going to be just PEP. PEPs. Yeah, it'll be PEPs. We can handle that. Unfortunately, we still don't know what causes it. Again, a lot of associations, but I wish we understood it better. You can see itchy, beautiful red bumps that often start in the periumbilical skin, sparing the umbilicus there. They call that the headlight sign, or more urticarial plaques. Obviously, treating this with topical or even systemic corticosteroids work. The one thing I always point out, though, is this can actually show up postpartum. So help your dermatologist if they don't remember that. It's a miserable disease, but has no adverse impact on pregnancy. One other disease you won't see much, but if you see a pregnant woman who's itching and actually has blisters or open skin, we need to think about gestational pemphigoid or pemphigoid gestationis. And this is a rare autoimmune blistering disease in which the woman develops autoantibodies to one of the adhesion molecules that actually holds the skin together at the dermis and the epidermis. And that's what this is showing right here in this little line. Sorry. It's an immunofluorescence stain there showing the epidermis. This starts anytime during pregnancy, usually between the second and third trimester. And when it first starts out, you can get these very itchy urticarial-like plaques, which often very quickly thereafter go on to become these tense subepidermal blisters. When they rupture, it can leave the skin open. The disease often flares at delivery, and it can recur during successive pregnancies, during menses, or with use of oral contraceptives. There is an association with prematurity and low birth weight. And interestingly, this is one of the diseases that the baby can be transiently affected by blisters. But the baby himself or herself would not have the disease. They just get the autoantibodies from mom. So we diagnose it by doing a skin biopsy. We can also do blood work. And we treat with oral corticosteroids while pregnant. Once delivered, we often will take the mom to more potent immunosuppressive agents such as mycophenolate mofetil, azathioprine, dapsone, rituximab. And even though the disease usually will gradually remit, it can be a matter of months, so we will often have to treat for a prolonged period of time. I just want to remind you and also that dermatologists that common things being common, you can have flares of common skin diseases during pregnancy. Interestingly, some improve, some worsen. Acne can get better, can get worse, depending upon the woman. Some connective tissue diseases improve, some worsen, or may even present during pregnancy. Psoriasis can flare, it can improve. We rarely see what we call impetigo herpetiformis. It's a horrible name because it's neither impetigo nor herpes. But it's really pustular psoriasis that flares during pregnancy. What I would like to remind you is to be aware of what drugs, if a dermatologist is seeing a pregnant woman, what drugs we're giving. Because I think the one area where we overlap potentially is with acne. And this is something I really yell at dermatologists about because we treat teenagers with acne, and I think we as a group forget to ask young women, are you pregnant or could you be? Because some of our most teratogenic or toxic drugs are actually used to treat acne. Isotretinoin obviously is the big one, but we give a lot of oral tetracyclines. We do occasionally prescribe oral contraceptives, and we're using more and more spironolactone, particularly on young women, because it turns out to be a very effective treatment for adult acne. Even some of our topical drugs are bad. Topical retinoids, probably safe because the absorption is not huge, but as a class, retinoids are teratogenic, so I don't really like those in pregnant women. And there is one topical retinoid you really do need to be aware of called Tazorac or Tazarotene. This is actually a pregnancy category X drug. And they interestingly put on the black box, they gave us a package insert and told us to do pregnancy testing 2 weeks before we prescribe it. Totally ridiculous because we don't have to do it successively or when we give it again, but that's what's recommended. So those are things we can use safely during pregnancy to treat acne. And remember that just because a woman is pregnant, you can't blame everything on the pregnancy. We have seen every skin disease known to man, including scabies. So remember, an itchy woman might have scabies. So if she's got a rash, we recommend gloves. So I'm going to stop there because I think I have 18 seconds to go.